Okay, our hilum is a region. So in the hilum, once again, it's not a specific structure, it's just a region where we have a whole bunch of different vessels. Pulmonary artery, pulmonary vein, lymphatics, primary bronchi, okay, nerve supply. Once we take in air, an air that comes in through the nose or through the mouth. Remember, we got our 3 regions of the pharynx. How you doing, Janelle? I gotta keep going. I can't go back. Got a lot of stuff to do.
Wait, is this continuation from the
Yep.
last one, right?
Okay, so we had our nasopharynx, oropharynx, where we could bring in air, down into the laryngopharynx, and then from there we go into our trachea. Okay. Remember, the trachea is held open by C-shaped pieces of cartilage. Okay, we want to maintain that airway so they look like the letter C. Okay. Okay, remember, anatomically, the trachea is anterior to the esophagus, and you can see that the trachea does maintain its shape because of the cartilage. The esophagus, once again, just a muscular tube for the passage of food. You don't do any digestive properties in your esophagus. It's just to get food from your mouth to your stomach. So once we're in the trachea, okay, eventually air comes down. We go into either the left or right primary bronchi, which will go into the left and right secondary bronchi, left and right tertiary bronchi. So as we go into different structures, the tubes just get smaller and smaller and smaller in diameter. Okay, but we can still see all of these structures. So we cut you open, we look at your lungs, we can still see all of these structures. From tertiary bronchi, we go into bronchioles. Okay, once again, just a smaller tube. Then terminal bronchioles, once again, smaller. And eventually from terminal bronchiole, respiratory bronchiole, alveolar ducts. Then we get into this cluster, okay, which are called alveolar sacs. So they look like clusters of grapes. Those are called your alveolar sacs. And then each grape will be an alveolus. Okay, alveoli, if anyone took Latin, is plural, US is singular. Right? And it's down in here, okay, at the different alveolus, where we're going to have the gas exchange. So you can see covering it is a capillary bed. So over here is our capillaries. Normal lung tissue. So once again, if you're looking at a slide, you want to look what normal looks like. This is what normal lung tissue would look like. And obviously, if it doesn't look like this, then it's abnormal. Something's wrong with your patient. Okay. So here at the alveolus, here's where we're going to have diffusion of your CO2 and your O2. Remember that all of your deoxygenated blood came to your lungs, right? And it's in your bloodstream. Now what happens? It has to leave your bloodstream, get into the alveolus, then make its way to the alveolar sacs, alveolar ducts, respiratory bronchioles, all the way back up to your trachea, and eventually you expel it from your body. At the same time, you're breathing in. So now air, O2 is coming in, once again, either through the nose or the mouth, down the trachea, making its way through all those tubes, eventually getting to the alveolus, where it now has to get into your bloodstream. And that's where, what vessel brings that oxygenated blood back to the heart? The pulmonary what? Veins, okay? Remember, they're oxygenated. So now all that oxygenated blood, okay, gets back to the heart, and you can circulate it into your systemic circulation. So it's down here at the alveolus where you're going to have that gas exchange, okay? And that's because all those capillaries, okay, are in extremely close proximity to the alveolus. Now the lungs themselves, have different membranes that cover them. So we just go back for a second. Okay. Covering the lungs, just like covering the heart, it's covered in a tissue called the visceral pleura. And if we were to take your lungs out of your thoracic cavity, take your heart out, there's a lining of that cavity called the parietal pleura. And just like there's that covering of the heart, so between the heart and this tissue, there's a little bit of a space. So between these two tissues, there's a space filled with a little bit of fluid. So as your lungs expand and contract, there's no rubbing. Okay, you could breathe in, you could breathe out, and there's no friction between tissues. Okay? Sometimes people get what's called pleuritis, just like you could get pericarditis. So anywhere you have fluid, you can have inflammation or infection. Okay? So that can happen. Now if you look anatomically, look at the apex of the lungs. They're just a little bit superior of the clavicle, so they can be prone to injury. So if you break your clavicle, you can rupture lungs, so you do have to be careful. Just like if you fracture a rib, you can also puncture a lung. Okay? So even though they are protected within those bony structures, we still have to be careful. All right, so this brings us to our first gas law. And before we get to our first gas law, we got to go over a couple of different definitions. One is pulmonary ventilation, the next is external respiration, and the third is internal respiration. So with pulmonary ventilation, okay, I'm going to read you the definition a couple of times, that way you can get it down. So with pulmonary ventilation, you have the inflow and outflow of air. Okay, you have the inflow and outflow of air, and it involves the exchange of air between the atmosphere, okay, so the air you're breathing in the room, and the alveoli of your lungs. So that means the air outside of your body down to that really small, tiny structure in your lungs. So once again, pulmonary ventilation, the inflow and outflow of air, involving the exchange of air between the atmosphere and alveoli of your lungs. Okay? The next, external respiration, involves the exchange of gases. So we're talking about gases. What gases are we talking about? CO2 and O2. Okay? Exchange of gases between the alveoli and blood in your pulmonary capillaries across respiratory membranes. So once again, external respiration involves the exchange of gases between the alveoli and blood that's in your pulmonary capillaries, traveling across respiratory membranes. Therefore, capillary blood will gain O2, so it's going to gain oxygen, and lose CO2, lose its carbon dioxide. Yep.
Yeah.
Therefore, the capillary blood is going to gain oxygen, because that means you're breathing it in, so isn't your blood going to be gaining oxygen that way? And losing CO2. Internal respiration involves the exchange of gases between blood in systemic capillaries. Okay, remember the first one was pulmonary capillaries, so that was your pulmonary circulation. This is your systemic circulation. So it's an exchange of gases between blood in systemic capillaries and tissue cells. Blood will lose its oxygen, okay, because does an artery bring blood to a tissue? So if the artery brings blood to a tissue, what's going to happen to the oxygen? It's going to leave the blood and go into the tissue, into the organ, okay, gland, and it's going to gain CO2. Page 7, under pulmonary ventilation. Roman numeral 2. Roman numeral 2. Those definitions aren't there. That's why I'm reading you those definitions. The terms are there, but the definitions are not. Okay? So once again, pulmonary ventilation, the first one. Inflow and outflow of air, involving exchange of the air between the atmosphere and the alveoli of your lungs. Okay? Breathing in and out. Air gets in, air gets out. The atmosphere, okay, air in a room. Alveoli are the tiny little structures in your lungs. External respiration. Okay? With external respiration, that's going to be involving the pulmonary circulation. So you have your exchange of gases between alveoli and blood in pulmonary capillaries across respiratory membranes, where your capillary blood gains O2 and loses CO2. Internal respiration, you have your exchange of gases between blood and systemic capillaries and tissue cells. Blood loses O2 and gains CO2. So we have those terms, which brings us to our first gas law called Boyle's law. Now, Boyle's law states that the volume of a gas varies inversely with pressure and has nothing to do with temperature. Right? So we don't take temperature into account. So it's strictly a volume and pressure. So if we look at this little diagram, here we have a cylinder that has a specific volume to it, okay? And it has a specific pressure to it. So if we measured the volume, it may measure 1 liter. And if we measure the pressure, it may read 1 atmosphere, okay? Now, if we compress down the gas, okay? We compress down the gas, what's happening to the volume of the gas? It went in half, right? We compress it down, we cut it in half, right? Is that what the picture shows us? But when we do that, because we're talking about an inverse relationship, remember an inverse, if something goes up, the other's got to go down, okay, and vice versa, okay? Pressure doubles, okay? So if we half the volume, the pressure will double. There's our inverse relationship, okay? One of them went down, therefore the other went up. Okay, so Boyle's law states that pressure has an inverse relationship to volume. I'm going to see that again in a second. Now, when we take a breath in and when we take a breath out, it's not just a simple, okay, oxygen is coming in our body, carbon dioxide is leaving our body. It involves a whole bunch of different muscle groups. So if we breathe in, look at the different muscles that we have to use. Right? We take a breath in, we're using the sternocleidomastoid or the SCM muscles. Okay? We're using our scalenes. Okay? Remember those little tiny muscles anterior to the neck. We have our external intercostals, okay, between our ribs because they're going to help elevate the ribs. Okay? And we have our diaphragm. So when we take a breath in, what's happening to the volume of your thoracic cavity if the ribs are elevating and expanding and the diaphragm drops downwards? Okay, what's happening to that volume? It's increasing, right? We're increasing the volume. Everybody see that if you take a deep breath in, you're increasing the volume of your thoracic cavity, right? Right? Now, if we breathe all the way out, we use our internal intercostals to bring the ribs back down. We use our external obliques, internal obliques, transversus abdominis. Okay, we learned those all last year. You probably wondered why we had all those different muscles, what we use them for. Well, we use them for daily respiration. We also have our rectus abdominis. Okay, so when those muscles contract, what happens to your thoracic cavity? The volume. It goes back down, right? It decreases. Okay, so keep that in the back of your mind. On inhalation, the volume of your thoracic cavity gets bigger. On exhalation, it gets smaller. Okay, so you can see what happens with the volumes when you get to pressures in a second. Because when you take a breath in, it's not just expansion and contraction of your thoracic cavity. We also have to deal with pressure changes. Okay, but once again, you don't have to think about the pressure changes because they happen automatically. Right? Don't you expand and contract your lungs without thinking about it? Just like your heart beating without you thinking about it. Okay? So here, we're going to talk about the pressures. Okay? Now, when we talk about atmospheric pressure, that's just the pressure in the outside air, or the pressure in a room. That's what we consider atmospheric pressure. And just like any pressure, you can measure it. You measure it with a barometer. Okay? You just listen to the weather. They'll tell you the barometric pressure was whatever. Okay? And it gets measured in millimeters of mercury. Okay? So for this example, we're just going to say that the atmospheric pressure was 760 millimeters of mercury. Everybody okay so far? Yes? All right. So at rest, okay, the diaphragm is in a relaxed state, and we can measure different pressures in our lung fields and in our thoracic cavity. Some of the pressures we can measure are the alveolar pressure. Where are the alveoli? They're in the lungs. We can measure that pressure. We have instrumentation that will give us a measurement. Okay? The intrapleural pressure is the pleural cavity, the cavity that surrounds your lungs. Okay? Everybody good with those? Okay. So we have measurements. We're at rest. We give them certain numbers. Okay? Alveolar pressure at rest means you're really not taking a breath in, you're not taking a breath out, you're just kind of like calm. Okay, so you're not taking a test, you're not nervous, you're not panting, and you're not hyperventilating yet. Okay? Now, we're going to inhale. We're going to take a deep breath. Okay? What just happened to our thoracic cavity? It got what? It got bigger, it increased, right? Look what happens to pressures. Okay? Alveolar pressure at rest was 760 millimeters of mercury. Okay? We took a breath in. The alveolar pressure did what? It dropped, right? It decreased. Okay? It went from 760 to 758. Okay? We had a decrease in the pressure. Look what happened to the intrapleural pressure. It did what? It dropped. What direction did your diaphragm move? It moves downwards to help in the expansion of that thoracic cavity. So on inhalation, okay, what happened to the thoracic cavity? The volume got bigger. And what happened to the pressure? It dropped. There we have your inverse relationship. Okay? Now, we want to get the air out of the lungs. Okay? We're going to use those muscles of exhalation. Okay, all those abdominal muscles, internal intercostal muscles. Okay? So now they've contracted, the diaphragm pushes back up. What happens to the volume of your thoracic cavity? Got decreased, right? But in order to get the air out, what's going to have to happen to pressures? If we know if the volume got smaller, the pressure has to go up. So let's take a look. Okay? Alveolar pressure. What did it do? It increased. Intrapleural pressure. What did it do? Okay, it went up. It increased. So therefore, we have our inverse relationship. Here are your lungs, okay? My two little balloons, okay? Here is your diaphragm, okay? Here is rest. Look what happens to the balloons if I take a breath in. What do? They expanded, right? Diaphragm drops. Technically, it created an increased volume here. It took the pressure off of the balloons. They can expand. I take a breath out. Look what happens. Diaphragm goes up. Balloons deflate even more. And you can expel out. Okay? It would almost be equivalent if I stand next to her right here. Okay, she doesn't have room to move. Okay? But if I just take a step away, now she has room for expansion. Bless you. Same thing with your lungs. If you drop the pressure, the lungs can expand. If you put pressure up against the lungs, now they're going to get squashed and push everything out. Okay? Everybody follow this concept of Boyle's law. Inverse relationship between pressure and volume. Okay? Once again, temperature has no bearing. We don't even take it into account. Janelle.
You said when you exhale, the diaphragm
pushes up.
Okay.
Look at the direction of the arrow. It pushes up. Because what do we want to do on exhalation to our thoracic cavity, pleural cavity? We want to squash it. And by bringing everything back down, it pushes and squeezes the air out of your lungs. Okay? How do you get water out of a sponge? You squeeze it, right? And then all the water comes out. How do we get air out of our lungs? We don't want to squeeze them, but we want to put some pressure on them to expel the air. So it involves muscle contraction, which changes our volume, and it involves pressure changes as well. Is everybody good with that? Yes? Once, twice? Yeah? Sure that you're just placating me, or sure you understand it?
It's not understand it.
Right? If you understand it, then that's good. We can move on. Right? So, when you look back at the picture, just keep in mind the inverse relationship that you have between the pressure and the volume. If one goes up, the other's got to go down.
So you would give an example of if someone has a fever, so their temperature went up.
It wouldn't even be that complicated. It wouldn't even be that complicated. It could be as simple as on inhalation, what happens to the pressures in the alveolar pressure and the intrapleural pressure. Or on exhalation, what happens to the pressures? Or I could ask you about Boyle's law. Yes.
But during exhalation, they both go up.
Yes, they need to both go up because you got to get the air out. Because they're the pressures, okay? These are the pressures, and here is the volume. So they have to go up because the volume got what? Smaller. Okay? So the muscles of your body help take care of the volume, right? Getting it bigger or smaller. And then the pressures, okay? One is inside the lung, one is pushing up against the lung. And they help squeeze all that air out. Just think of it as like a sponge. You wet it, okay? That gets water into the sponge, but how do you get the water out of the sponge? You got to squeeze it, apply more pressure. When you get less pressure and loosen up your hand, then it could fill back up with water.
Can we ignore the integral number and just stick with the concept since the number went down?
None of these numbers I want you to memorize.
Okay, so just
Okay?
the concept.
I want you to get the concept exactly of what's happening. Because down the road, if I need to, I'll just give you any numbers. Okay? So don't memorize atmospheric pressure. Don't measure alveolar pressure. Don't memorize those. Okay? If there's a specific number I want you to know, I'll let you know. Like the pH of the blood was something you wanted to know. Okay? But don't memorize these numbers, okay? They're just here for an example. All right. Now we come to another thing. Okay? This is what's called a spirometry graph. Okay? Now your lungs take in air, they let out air. We could tell how poor or how well you're breathing through what's called spirometry. You breathe into a tube, it prints out a graph, and the graph has meaning to it. So we're going to go through it. And once again, you see the numbers on the graph? Don't memorize them. I'm going to give you new numbers. Okay? I want you to know how to read the graph and what it means. Okay? It's very simple. On this side of the graph on the left, we have what are called your lung volumes. And on the right side of the graph, we have what's called your lung capacities. Okay? Your lungs can hold a certain amount of air. They can let out a certain amount of air. Okay? The regular numbers, okay, for this example are males. The ones in parentheses represent females. Okay? Because females tend to have a smaller stature, therefore they have less air in their lungs. Okay? So let's look at the different volumes. Okay? First of all, we have this area here called your tidal volume. Your tidal volume is basically you're at rest. So how much air is in your lungs at rest? You haven't taken a deep breath. You haven't forcefully let air out. You're at rest. So tidal volume represents the amount of air in your lungs at rest. So at rest was this picture, at rest. Okay? So we can still measure how much volume is inside. Okay? Now, moving up from the graph, so this area in here, that represents inspiratory reserve volume. Breathing normally. Everybody take a deep breath in. That's your inspiratory reserve volume. How much air you were able to get inside your lungs. Okay? So that would represent an upward spike. Okay? And we can measure that. Okay? In males, it would be about 3,100 mLs. Females, 1,900 mLs. Once again, don't memorize the numbers. Understand the concept and how to read the graph and how to use the graph. So everybody good with tidal volume? Air at rest, inspiratory reserve volume, how much air you just brought in your lungs. Okay? Okay, once again, everybody take a breath in. Let it out. Okay? When the air that you just let out, that's your expiratory reserve volume. How much air you let out of your lungs. Okay? That is this part of the graph. Okay, all in here. Okay? Everybody good with that? Okay, so we have our resting volume, we have our inspiratory volume, now we have our expiratory volume, now we have what's called residual volume. All right, so we're at rest. Take that deep breath in, let it out. Keep going, let it out, let it out, let it out, let it out, let it out. Do you think your lungs deflated? No. Okay? Your lungs will never, ever fully deflate. Okay? You're always going to have some air left over even after you've expelled what you think you can. That is your residual volume. How much air was left over in your lungs even after you were breathing out for seconds and seconds and seconds. Okay? So your lungs will never ever deflate unless they're punctured or injured. Okay? We have what's called surfactant, which helps keep the lungs open. Okay? So those are the volumes that we have. Okay? Now, we look over to the right, we have other measurements. We have different capacities. Your inspiratory capacity is made up of two different volumes. Look at the arrow. It's made up of your tidal volume plus your inspiratory reserve volume. Okay? So here you have 3,600 mLs. Well, how did they get that? They added 500 to 3,100, and they got 3,600. So they added this volume to this volume. And that's your inspiratory capacity. Because remember, at rest, you are taking air in, and then you are eventually taking a deep breath in. You have your functional residual capacity. Right? Let's look at the arrows. That's going to take into account your expiratory reserve volume and your residual volume. Okay? 2,400 mLs, because they added the 1,200 and the 1,200. Okay? We're going to skip vital capacity for a second and go into total lung capacity.
But why is there a difference in the expiratory reserve volume for women and the residual volume for women? See how in the men it's 1,200 and 1,200, and then in the women it says 700 and 1,100?
Right, because of what, here and here?
Yeah.
Well, these are two different volumes.
Right, so
I guess
why is
you're,
it the same for men and not the same?
Oh, because I say, this might end up being a typo because there's no way that you're keeping that much in your lungs. Okay, that side might be a typo. There's no way when you breathe out that you still have 1,100 mLs of air in your lungs. Good catch.
But men could have 1,200? Is that what it says for men?
Well, you're breathing in 3,100, and then what you're breathing out is 1,200. So that afterwards it'll be that's what you're breathing out. How much you're breathing out? How much of the air you're breathing out? Janelle. Yeah, we didn't get through that one. So functional residual capacity.
But you said something before that, did you explain it or did you say we explain it? 'Cause I didn't kinda-
No, we were gonna skip vital capacity for a second.
Okay.
But the functional residual capacity, if you look at it, it's adding that expiratory reserve volume and residual volume. It's adding them two together. Here's what I said, we're gonna skip vital capacity for just a moment. Look at total lung capacity. Total lung capacity, okay, we're adding up all of your volumes. So just think the word total in it, okay, total lung capacity. So adding up your inspiratory reserve volume, your vital capacity, your expiratory reserve volume, and your residual volume. Adding up all those four volumes, right? And that's where you get that 6,000 mLs from. Okay, so it's adding up all of the four volumes. Now the one we skipped was called vital capacity. And in its name, it says vital because that's going to tell us specifically how well or how poor our lungs are doing. That's why we call it vital. Okay, look what it's taking into account. It's taking into account our resting volume, right, the tidal volume, how much air we can take in, inspiratory reserve volume, and how much air we can let out, your expiratory reserve volume. So how well can we breathe in and breathe out? Okay. So for those that like equations,
Oh, yes, all of them.
you know, if you wanted to, you can write it as your inspiratory capacity, okay? And what does it equal? It equals your inspiratory reserve volume plus your vital capacity, right? Inspiratory capacity equals your inspiratory reserve volume plus your vital capacity. Functional residual capacity. ERV, okay, plus RV, okay? Functional residual capacity, expiratory reserve volume, and residual volume. Vital capacity, inspiratory reserve volume, plus your vital capacity, plus expiratory reserve volume. And then your total lung capacity. Inspiratory reserve volume plus capacity plus ERV plus RV. This should be title one. Keep writing VC. Sorry. Okay. So it just depends if you're a more visual person or you're more mathematically minded person. Okay. So it doesn't matter what numbers I give you, because all you need to do is look at the chart. Right? So let's say we made up numbers and we had okay, let's say we had those numbers. Okay. Well, one, you could look at the chart and you would see what the different volumes measured. Okay, so it would be there on the chart. So if we asked you to pick out what the tidal volume was, okay, 350 mLs. If we asked you to calculate the functional residual capacity, what would it be? What would be the answer?
1400.
1400, right? Because we gave you numbers, and you know that your functional residual capacity added these two volumes together, and you would be able to come up with the answer. So that's what I'm telling you. Don't memorize any numbers. I'm going to give you numbers. You will absolutely see this on your next test. So I want you to know how to read the graph. What does it mean? How do we add what numbers together? Right? Once again, we want our total lung capacity. What are we going to do? We're going to add all of those volumes up. So 5,000 plus on the 1,400 is 6,400 plus 350 is 6,750. Okay? And that would be your total lung capacity for this example. Once again, volumes will be given to you. The only thing that you're not going to have are the names put in there. So you're going to have the wave put in.
Hours?
You'll have the green lines. And you'll have the arrows. That's it. So you're going to have to know, what does this top portion mean? What volume is it? What volume is this? What volume is this? And what volume is this? But you will see a number there. The arrows will be drawn in. You have to know what capacities they are. That way you can figure out the answer. You won't need a calculator because it'll be nice whole round numbers. Okay? So, just a matter of, can you look at the graph with the data that you're given and come up with the answer. Alright? I'm letting you know, this will absolutely be on the next test. So make sure that you look it over if you're not sure. Anybody have any questions? Do you want to go through it again? You understand it? Alright.
I don't understand how they're able to tell what you got in your inhalation, because they don't, I mean, from my experience, they don't have you breathe in with the tube in your mouth, you breathe in.
They can do the but they can do the calculations by the process of elimination. If they know what your lungs can expand to and how much you breathe out, then there's a difference of certain mLs because they know what your resting volume is also going to be.
What would like FEV be? I know that's
Right. Well, you're going a little bit beyond, so just
Okay.
stick to this concept. All right. When we want to look at your lung capacity, how much air is inside, we use what's called spirometry. Just breathing, breathing in, breathing out. By doing that, we can measure volumes of air. So when you breathe in through a spirometer, you're going to get a graph reading, almost like you'll get a graph reading from an EKG or graph reading from your action potentials. Okay? So the graph means different things. On the left side, we have different volumes. On the right side, we have different capacities. At rest, okay? You're at rest, you're just breathing normally. Normal breathing. That is your tidal volume. Okay? How much air is in and out of your lungs at rest. You can measure it. Okay? That is tidal volume. Take a deep breath in. That is your inspiratory reserve volume. How much air you just got inside of your lungs. We're breathing normally. We took a deep breath in. Now we expelled out all our air. That is your expiratory reserve volume. How much air we got out of our lungs. Once we breathe out, okay, the lungs never fully deflate. They stay open. There's air left over. That's residual, your residual volume. How much air was still left in our lungs even after we took a breath in and breathed all the way out. Okay? So those cover our different volumes. Right? Your normal breathing volume, air breathing in on inhalation, air out on exhalation, and what's left over. Right? Now with those, we can calculate what we call capacities. We have different capacities, okay, which can just measure the amounts of air either taken in, taken out, how much or how well or how poor our lungs are performing. Okay? So our inspiratory capacity is taking into account your normal breathing, your tidal volume, and your inspiratory reserve volume. Okay, how much air you just took in. So there we have IC equals IRV plus TV. You look at the graph, read off the number, add those two together, boom, you got your inspiratory capacity. Your functional residual capacity takes into account the air that you breathed out, plus what's left over. Vital capacity, how well did your lungs take in air and let out air? Okay. So it adds your resting volume, intaking of air, your inspiratory reserve volume, and the expelling of air, your expiratory reserve volume. And then total lung volume and total lung capacity just adds all the different volumes together. So all four total. Okay, so you're adding up the inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. Okay, we're just adding them all together. Okay. So make sure you look it over again, because once again, you will see this on your lecture test. Now we're getting to the part where we are going to talk about how do we get oxygen circulating in our blood. How do we get carbon dioxide circulating in our blood and eventually out of our body. And we're going to come to another gas law. So to understand the exchange of oxygen and carbon dioxide between blood and the alveoli, we have what's called Dalton's law. Okay, Dalton is the second gas law, okay, which states that each gas in a mixture of gases exerts its own pressure as if all other gases were not present. So when we had this atmospheric pressure, and we had it at 760 millimeters of mercury, well, what does it mean? What does that number mean? How did we get to 760 millimeters of mercury? Because it's just a number. But that number is because in the atmosphere, isn't there a whole bunch of different gases? Okay? We have nitrogen gas, we have oxygen, there's water, there's CO2, okay? Plus a small percentage of other gases. So that's gonna help make up that 760 millimeters of mercury. Okay? Each gas has its own pressure to make up the atmospheric pressure. Okay? So in the 760 millimeters of mercury, we have nitrogen, we have oxygen, okay? We have water, we have CO2, plus other gases. Yep.
Sorry, do you mind repeating the deltas on?
Each gas in a mixture of gases, which is what your atmosphere is, it's a mixture of gases, exerts its own pressure as if the other gases weren't present.